Thank you very much. I want to thank the organizing committee, Dr. Louis, Patrice, the association, for inviting me, for the privilege of being here today. Like some of the other speakers, actually this is my very first time in Iowa, so it's been a very, very positive experience, so I appreciate that. I also want to thank Patrice and the organizing committee for making sure I'm the first speaker in the postprandial hour. That's almost always a challenge, particularly after the wonderful lunch they served us. Yeah. So I'm going to talk a little bit about postural dizziness in patients with Chiari malformation. And for the purpose of the topic, I really have no disclosure. Let's see here. I do this. It's not advancing. Okay. Mm-hmm. So postural dizziness in Chiari is a complex syndrome. Yeah, it's right. Yeah, and one way to think about it, usually, most patients will have dizziness when they are changing their position into standing or rapid sitting, you know, what we call orthostasis. And orthostatic intolerance takes one of two common forms. One of them is known as postural orthostatic tachycardia syndrome, also known as POTS, which I will refer to as POTS in this topic. And the other one is orthostatic hypotension. But patients with Chiari also can have other causes of postural dizziness, and I will talk about those briefly. It can include vestibular and cerebellar components. And in many patients who have protracted postural dizziness, usually autonomic testing can be helpful, and then you really need to approach them in a multimodality fashion. If you look at the symptoms of orthostatic intolerance in dysautonomia in general, lightheadedness is incredibly common. It's basically up to 95% of the patient. That's how they present. Dizziness is the next most common, then exercise intolerance. And then there is a whole host of other symptoms, and I would say some of the common ones that can be very vexing to patients and physicians is the chronic fatigue, as well as some of the other problems. You've heard some of these topics on headache. We see syncope and shortness of breath, which sometimes can be orthostatic. So these can be all symptoms of orthostatic intolerance. This is from a classic paper by Dr. Milorad, where he looked at patients, 364 patients with Chiari. And he put down all the symptoms here in terms of frequency, but I put arrows on what we consider essentially autonomic symptoms, one way or another. So dizziness is a very, very common one. You know, dysphagia, you may think it's not autonomic, but when it happens, it suggests vagus nerve problem. And when the vagus nerve is affected, it's seldom just confined to dysphagia. There is usually something else going on with these patients. Gastric motility issues, colonic motility issues, cardiac sometimes problems with propensity to tachycardia. Sleep apnea really is a form of autonomic disorder. And then palpitations, they can be very common at rest, but they increase with change of position, and therefore these patients sometimes have POTS. So up to 1 in 4 patients occasionally can present with POTS with this condition. So I'm going to start one by one. So orthostatic hypotension is basically defined as a sustained drop in the blood pressure, systolic blood pressure by more than 20 millimeter mercury, or diastolic by more than 10 millimeter mercury within 3 minutes of standing. But if you have been hypertensive for a long time, the criteria become a little bit more lax, and then you require a drop of the blood pressure by more than 30 millimeter if it is systolic, or 15 millimeter is diastolic. Orthostatic hypotension actually is quite common. It's about 6 to 10% in middle-aged population, but it increases as we get older. Many other autonomic conditions also worsen as we age, and it can be more than 20% in patients who are older than 75. What are the symptoms? Usually the symptoms are due to the fact that there is decreased blood flow to the brain when you're standing or if you're exercising in the upright position. So the symptoms will be in the form of lightheadedness when you stand, which is the most common presentation. When the drop in the blood pressure is very severe, there is enough interruption of the blood flow to the brain that basically you would faint, and that's known as syncope. So syncope is fainting. And then triggers beside, prolonged standing or exercise particularly will be, for instance, prolonged bed rest after a surgery in which you are immobile, for a couple of weeks. Food ingestion, if there is food poisoning with vomiting and diarrhea, you get dehydration, or sometimes a heavy meal. Alcohol ingestion, particularly if you're very sensitive to the dilation effect of the blood vessels from alcohol. Anything that dilates your blood vessels, so fever, heat, exercise, particularly in the heat, in a day like today, you can go for a walk and you will feel a little bit lightheaded because of mild orthostatic hypotension. Hyperventilations, sometimes medications, usually in combinations. So the classic ones will be like if you're on 2 or 3 medications to treat high blood pressure, and if you become sensitive to the medication, you can develop orthostatic hypotension. If you have some type of a bad infection that produces diffuse sepsis, it can cause that, and then sometimes generalized surgeries. The indirect symptoms, so direct is lightheadedness and near fainting or fainting. Indirect symptoms will include dizziness. Older patients with mild orthostatic hypotension, sometimes they feel imbalanced. They tell you, I walk like I had a couple of extra drinks, but I did not drink too much. And then fatigue and weakness is very common. And then occasionally falls. We've had older patients particularly who drop their blood pressure and then they fall. And they can fall usually forward, but sometimes backward, and they can have injury. A common symptom also that's fairly vexing to the patient and physician is the so-called brain fog. Patient will come and tell you, I have a brain fog, which is very difficult to discern. You ask them about it. And in some of these patients, when we send them for neuropsychological testing, for quantitative memory testing, they do not have a specific deficit in one domain. Like, for instance, you see in Alzheimer's disease or some type of dementia. They will tell you, the neuropsychologist will tell you they have slow processing of the entire brain. The brain is working fine. It's just taking them much longer to process everything, either when it's coming in or coming out. So it has something to do probably with the blood flow to the brain. Some patients, particularly if they've had dysautonomia with chronic orthostatic hypotension, will describe this phenomenon. They will feel like somebody's putting a heavy weight on their neck and shoulders. They will tell you, I'm feeling like I'm wearing a cape. And they have that usually sometimes without the lightheadedness. So that can be a red flag when this happens. Some patients will describe chest pain or dyspnea. It's usually either when they are standing a lot for a long time, they feel short of breath. A common phenomenon we see in patients with dysautonomia is they develop dyspnea at elevation. So, when they go to Denver, for instance, or like in California to Lake Tahoe, or if they are on a long flight, traditionally more than 2 hours or so, they will tell you, past my second or third hour on the flight, I become a little bit short of breath. And these are some of the symptoms that could be a red flag that they are having hypotension and can be a dysautonomia. And then, we already heard a lot about headaches, so I won't bore you, but some patients with autonomic dysfunction, and Chiari in particular, have headaches when they are standing. And they are not always related to CSF leak. They can just be due to the fact that they are dropping their blood pressure when they are standing. So why does this happen? Why do they have all these problems? So when you stand, the physiology of standing is basically you begin to dilate the blood vessels and the gravity pulls the blood down below your belly button. And you get about 300 to 500 cc's minimum in most people. Some people up to 700 milliliter or cc of blood will shift down to the body. And when this happens, few things happen. First, you're dilating the blood vessels. So you're activating the stretch receptors in the arteries, and you're telling them something is happening here, maybe you should react, number one. Number two, you're reducing the amount of blood that's returning to the heart because the blood is following the gravity. And based on this, there is a variety of autonomic reflexes that we group as baroreflex, baro as in barometric pressure, baroreflex, and it's pressure sensors in the arteries that make sure that you begin to have a vasoconstrictin in the blood vessel. So the blood vessel that dilated now begins to tighten up again, and as a result, push the blood up into the heart, and then you prevent the drop in the blood pressure. So when you stand up, again, you shift about half a liter of blood, and then there is some shift of plasma volume to the outside of the interstitial space, which is between the cells. And this combination of both now all of a sudden is reducing the amount of fluid and blood available to your upper body, including your head. And so in a normal person, when this happens, your heart rate is going to increase to compensate for this drop in the blood flow and the return of the blood to the heart. And basically you increase by about 10 beats per minute. That's a normal response. And then usually your systolic blood pressure, which is the higher number, stays about the same. And your lower number, the diastolic blood pressure, increases by about 5 millimeter because this is a measure of how well you're constricting your blood vessels. So that's basically the physiologic normal response in a person. And like I said, this is mediated by this area in the brainstem here. that sits in front of the cerebellum that's known as the baroreflex area. And that area receives information from the blood vessels that dilated because the blood is going down with the gravity. It also gets information about the heart rate, and you get this biofeedback loop, I won't bore you with the details, by which you get constriction of the blood vessels to reduce the amount of blood that goes with the gravity, and you get increase in the heart rate by withdrawing the vagus nerve to make sure now there is adequate perfusion to the tissue. And the reason I wanted to show you this is you've seen now enough pictures and all of you are expert enough. You know, that's the area where Chiari pathology is, with or without syrinx. So patients who have Chiari, particularly if they have syrinx, if it's a small cavity, they actually have a precarious and fairly ticklish, if you will, baroreceptor circuitry. And that sometimes they can make them more liable to having orthostatic hypotension or tachycardia or both. So when we evaluate patients with orthostatic hypotension, we look at two parts of the phenomenon. The first one is the timing of onset. When does the orthostatic hypotension happens? And there are 3 times zone. One is called initial, and I'll show you slides of that, early and delayed. And then equally important is how well your heart rate responds. So remember, when you drop your blood pressure, your heart rate should increase. So is the increase adequate or not adequate? And we define this as non-neurogenic versus neurogenic. These are examples of patients who are being tilted. The same applies to standing. And in this particular diagram, you know, the blood pressure, systolic, that's the higher number, diastolic, lower number is in purple or burgundy, and then the heart rate is in green. And with initial orthostatic hypotension, as soon as you stand, you drop the blood pressure rapidly, but the drop usually recovers within 1 minute, occasionally 2 minutes, but most patients it recovers within 1 minute. This is called initial orthostatic hypotension. Those patients typically are at their worst when they stand up immediately. And in fact, those patients, we do the tilt, and then we have another test in the autonomic lab where we do a rapid standing test after we do the tilt. And when you have them stand up, they drop even more, and sometimes that's when they faint. And that seems to be a syndrome that's fairly unique to patients who are adolescents, young, or patients with elastic tissue disorder. They seem to have this problem. The other form is orthostatic hypotension, where you basically drop and you keep staying low, and then the heart rate increases until you tilt the patient back and then they recover. But in these particular cases, there is an adequate increase in the heart rate. An adequate increase in the heart rate is defined by the American Autonomic Society and the American Association of Cardiology as an increase in your heart rate by 1 beat for every 2 millimeter drop. So if you drop 20 millimeter and your heart rate increases by more than 10 beats, that's considered adequate compensatory tachycardia. If you drop by 20 millimeter and your heart rate goes up 5 beats, this is inadequate. And inadequate will mean this is neurogenic. And we call it neurogenic because those patients mean they have dysautonomia. So not everybody who drops their blood pressure has dysautonomia. But if you drop your blood pressure and your heart rate does not increase, it's almost guaranteed that you have dysautonomia. So that can be a very easy thing to follow. And that's what we call neurogenic orthostatic hypotension. Delayed orthostatic hypotension is another less common form, but we see it sometimes in patients with Chiari. Those patients will feel okay the first 3, 4, 5 minutes, you know, and then after 7 minutes, 8 minutes, they start feeling a little bit lightheaded. Or they'll do okay, but then they go on a hike. And 10 minutes, 15 minutes into the hike, they are now very fatigued and lightheaded. And some of them say, well, I just can't come back. You know, I know if I go on the hike, I can do the first leg of the hike, but I cannot do the leg back, you know, and I need some help. And then finally, some patients just will literally pass out. You know, so you tell them they go tachycardic, then the blood pressure drops and they faint. And then some patients will have the so-called POTS, postural orthostatic tachycardia, where the blood pressure does not drop. It stays stable, but the heart rate increases dramatically. And I'm going to talk about that because that actually is reasonably common in Chiari. So POTS is a very common condition of orthostatic intolerance as well. And I might add, it's more common in younger patients than orthostatic hypotension. And it's defined by an increase in your heart rate by more than 30 beats when you stand. That's in adults. And up to the age of 19, pediatric and adolescent, it's an increase in the heart rate by more than 40 beats. And the increase has to be sustained for at least 3 minutes, and it has to be associated with symptoms. There are some patients who increase their heart rate, but they have no symptoms, and we're still trying to understand why. But the majority of patients will have symptoms. The other thing that can define POTS is if you have a sustained heart rate when you're standing or being tilted up, exceeding 120 beats per minute. So that is accepted as a criterion as well for POTS. And usually, typically, it happens in the first 10 minutes of standing or tilt. And the key thing is there should be no orthostatic hypotension. If the blood pressure drops quite a bit, but the heart rate increases 40 beats, probably the orthostatic hypotension or the blood pressure drop is the chicken, and the tachycardia is the egg. So that's something important to recognize. These are examples actually from our autonomic lab at Stanford. The red is the blood pressure, systolic blood pressure. I just kept it simple here. And then this is the heart rate. And this is an example of POTS number 1, where the heart rate goes up by more than 30 beats, but you see the blood pressure does not drop. It does not change. This is POTS number 2, where the blood pressure again does not change, but the heart rate exceeds 120 beats per minute for the entire duration of tilt. So these are two forms of POTS. So again, other criteria that's important is that the symptoms will get better if the patient sits down or lays down. So if they sit down or lay down and they don't feel better, maybe there is something else beside POTS. That doesn't rule out POTS, but maybe they have something else and you should think about it. Also, the academic and the physician association require that you have the symptoms for more than 6 months to basically diagnose it. And particularly, you need to make sure there are no other causes that are obvious. For instance, if they are very dehydrated, like I said, they had a GI illness, got dehydrated because of vomiting, diarrhea, or if they bled, they had a surgery and they bled, it is automatic to have high heart rate. So this will not be a diagnosis of POTS. What is not POTS? So sometimes we have to deal with this in the clinic. So patients who have tachycardia when they are sitting down or supine. Now, that doesn't mean those patients do not have POTS, but that is not POTS. If you have high heart rate, 90, 100, 110, sitting down or laying down, you really have what we call inappropriate sinus tachycardia. And that is a different phenomenon, and perhaps cardiologists usually should work you up for that. But if you have a high heart rate sitting down, guess what? When you stand up, you may go up above 120, and all of a sudden you fulfill the POTS criteria, because you don't have to increase by much if your heart rate is 100 beats per minute laying down. But you should be a little bit careful because the management of those patients is different and the workup is a little bit different. If the symptoms do not improve significantly when you lay down, or if the orthostatic tachycardia persists for a long time. I wrote 3 minutes, but actually many of these patients will be tachycardic. And it's interesting, we tilt them back and they are tachycardic. We sometimes monitor them for 3 to 5 minutes after we tilt them back in the autonomic lab. And you tilt them back, they are still 90, 95, 100, and it takes them about 10 to 15 minutes to cool down. They may have POTS, but they may have also something else. So you don't want to miss that something else. So this is very important to be aware of that. And then some patients will tell you, yeah, my heart rate accelerates, but the tachycardia or the increase in the heart rate is not very dramatic, but they have, spinning. They tell you the room is spinning, or I feel like, I'm leaning backward or forward. They have other phenomena, and I'm going to come to that in a minute. Yeah. So POTS is common. We think it's between 0.2 to 1%, but the prevalence, and while compared to syncope, which is fainting, the prevalence is 0.8 to 4%. But that's a lot of people, particularly if you think of young active people getting POTS. And it's usually a disorder of the young patients, 15 to 30 years. Women outnumber men by a lot. It really is 4 to 1, And there is a prevalence in Caucasian patients. White seem to get it more than African American or Latinos. And then hypermobility and EDS predisposes you to POTS. What are the triggers? What happens? Well, usually the common trigger is infection. And the most common, usually one are viral, and I put you the most common viruses. So, a typical one, an adolescent is healthy, active, exercising, they get mono. And then following mono, now they cannot exercise. When they go to exercise, they faint. They have all sorts of problems. Their sleep is dysfunctional. They have fatigue. We test them, they have POTS. It is post-infectious POTS. But other viruses that do it in kids, usually enteroviruses. In adults and kids, it's CMV, cytomegalovirus. We see it in a variety of things, and we are seeing more POTS after COVID. There has been an increase in POTS after COVID. Surgery, particularly if it's a pretty significant surgery, can cause that. And one thing that's relevant probably to the Chiari population is if you have a concussion or a head injury. So the classic picture is we get somebody on the volleyball team and they get, whacked on the head by their teammate or basketball, etc. And now they have POTS, even though they didn't have really typical loss of consciousness, they only had minimal concussion. And we examine them and we find subtle findings and we image them. Those are the patients that show up sometimes with Chiari. And that really is the presenting manifestation in some of these patients. Puberty is sometimes the reason for why it happens. Toxic stress, we have actually a study looking at that. If you're always, always stressed, particularly in a young age, you can develop that. Predisposing factor are iron deficiency and vitamin D. We look for them in everybody. And actually, if you correct them, you don't cure the POTS, but you make it more responsive to treatment. So it's important to measure that. And then some endocrine factor, like migraine, some women will have the attack of POTS worse around the time of their cycles. In between, they are fine. Thyroid and adrenal function we look for, and a very small percentage of women develop POTS postpartum. Yeah, we've had few patients like that. The clinical evaluation, you've heard a lot about EDS, so I won't bore you with the details. But one thing we look for is vasomotor pulling in the feet and legs, and sometimes the hands. Can be pretty impressive. And those patients sometimes are misdiagnosed as Raynaud, R-A-Y-N-A-U-D. It's not Raynaud. It's really they have vasomotor pulling. It's a vascular laxity in the blood vessels. You've seen slide about the Baton, so I'll skip that. But it's important to remember that POTS has comorbidities. So you can have, we talked about Ehlers-Danlos, we talked about Chiari, but you can have migraine headache. Migraine and headache are common in about 30 to 40% of patients with POTS. Sleep impairment and chronic fatigue can happen in some patients. The POTS symptoms are interesting because they mimic the symptoms of orthostatic hypotension. Yet there is no hypotension. These patients don't drop the blood pressure, but they have all the symptoms of a decrease in their blood pressure, which is really a mystery in this condition. And we think now, and other groups and our group have looked at that. And what happens though, when they have the episode or the attack of POTS, even though their blood pressure does not change, if you put an ultrasound probe on their arterial circulation in the brain and measure the blood flow in the cerebral artery, it decreases. So even though their blood pressure is totally fine, the heart rate is going, but there is less blood flow to the brain, and you can measure that by doing transcranial Doppler. So there is something, that affects the circulation of the brain. And many of these patients will feel, that they are going to faint, and they do have actually fainting, and there are various types of syncopes that happen for it. It's multifactorial as a condition, so probably the most common denominator is that there is volume depletion and deconditioning. A couple of other factors are if there is neurogenic or neuropathic POTS and hyperadrenergic POTS, and I will talk briefly about those. But volume depletion is very common and seems to be present in virtually every case of POTS. And this was a study that was done in Vanderbilt a while ago that looked at the blood volume, total blood volume, plasma volume, and red cell mass. There are ways you can measure that. And when they looked at general population and patients with POTS, will have both genders, but more pronounced in females. They will have basically a decrease in their plasma volume compared to control. They have a deficit in the red cells and deficit in their blood volume. And that seems to be due to the fact that they have chronic, low-grade chronic dehydration, if you want to think about it. So patients with POTS really think of them as low-grade dehydration that is fairly chronic. And that was pretty good group, actually. There's a group in Germany by Jens Jordan who replicated the data. So it's pretty reliable. How about deconditioning? Well, Benjamin Levine, who is a cardiologist at the University of Texas affiliated with the space program, they looked at astronauts. And what they did is they evaluated the heart rate of the astronaut basically about 72 days before the flight, about 23 days before the flight, and then they went and came back and they examined them at landing day. And as you see, 72 days before the flight, lots of these are healthy people, right? They are going to the space program. There is some increase in the heart rate when you stand, and then as become skilled with training and exercise activity before they go to space, the magnitude of the increase in the heart rate when they are tilted or standing up decreases. So if you're really an athlete and you're very, very well, training well, you will not increase your heart rate as much. But when they come back and land, they are far worse than they were even before they enrolled in the training program. And when they did ultrasound and echocardiogram on these patients, they found actually that the size of their ventricular chambers decreases a little bit, similar to what happens when you're bedbound for about 6 months. So therefore, that brought up the idea that deconditioning is a very important component in POTS. What other forms there are? Well, there is a form where your body makes too much stress hormone, noradrenaline and noradrenaline, and that's known as hyperadrenergic POTS. And those patients, when they stand or you tilt them, they make too much stress hormone, primarily norepinephrine and epinephrine. And those patients, because they make excessive hormones, not only they become tachycardic and have POTS, they also raise their blood pressure dramatically when they have POTS. And then also they have excessive blood pressure fluctuations. So here is an example of hyperadrenergic POTS. Again, same thing. Red curve is the blood pressure. Green line is the heart rate. As you see, the blood pressure increases, keeps increasing, and oscillate dramatically. Sometimes within a heartbeat, we have a device, laser device that measures beat-to-beat variation in the blood pressure. The blood pressure can change 30 millimeter within a heartbeat, and these patients are being tilted. And then the heart rate increases dramatically. And these patients will have other symptoms of adrenaline excess, including anxiety. And some of these patients are misdiagnosed as anxiety, and they get referred to psychiatrists. And then actually the psychiatrists send them to us and say, I'm testing this patient, and I don't think I think they are organic. Please test them. And we find they have hyperadrenergic POTS. And many of these patients will have also excessive sweating. They have tremor, and they have very commonly abnormal sleep. It's fragmented sleep. Good. So I showed you this. Okay. Patients with POTS, sometimes, particularly if they have rapid heart rate at rest, like this one, starting at a 90 to 100, sometimes they have arrhythmia. They get extra beats. And those we co-manage with cardiology, so that can happen. Patients with hyperadrenergic POTS may have a genetic defect. There is a gene that affects the way you recycle your norepinephrine, and there is a blood test for that. But also, you've heard about mast cell activation. Patients with mast cell activation will have hyperadrenergic POTS. And, and those patients will have also episodic flushing, rashes, etc. And we can send them to allergy colleague and measure also some of the mast cell activation measures. But, that's basically what happens. You're releasing variety of things like histamine, and you produce other neurotransmitters that basically activate the sympathetic system, lead to vasodilation and tachycardia. Dr. Maitland spoke about that a lot in the morning, so I'm not going to bore you with that. So how about neuropathic POTS? Well, that is usually post-viral. And that basically when patients will have not only POTS, but they have other neurologic autonomic symptoms, and the common ones tend to be GI. So those patients will have lots of GI symptoms. They have bloating, the digestion is not working. They have quote-unquote IBS, irritable bowel syndrome, constipation, diarrhea, or both. They have abnormal sweating problem. And when we examine them actually clinically, they usually have sometimes a small fiber neuropathy, or with or without large fiber neuropathy. And when we do their skin biopsy, you can quantitate the nerve fibers in the skin, and it's diminished. And that tells you that it's a neuropathic POTS. Other tests we do in the autonomic lab is we put a capsule test on their forearm, on their thigh, leg, and foot, and we measure their sweat function by trying to stimulate the sweating by passing a little current and iontophoresing acetylcholine. And normally you should sweat like that. And patients with neuropathic POTS, usually typically 1 or 2 responses will be flat or very small. That tells you they've had a nerve problem. Okay, how do we manage these patients? Well, non-pharmacologic measures first. Mechanical measures should be tried in every patient because they don't cause any side effects otherwise. Then there are pharmacologic measures, which I will go through. So basically the non-pharmacologic measure, you want to increase the fluid intake and you want to increase the salt intake. And the fluid intake should be about 2 to 3 liters per day. And I usually tell my patients measure it, make sure you walk around with a cup so at least you can see it. Salt intake can be pretty significant. So if patients cannot tolerate salt, we recommend salt supplement. And then compression stockings are very good because they will battle back that phenomenon of vasodilation in the leg. And there are various types of stockings that you can get. And many patients come to us really with the ones around the leg because they are more convenient, but those produce the least beneficial effect. If you look at patients here, this was a study that looked to see what happens to the blood flow and the heart rate, in patients depending on what socks they wear. The higher you go to the abdomen, the more effective you are in reducing the amount of heart rate increase. So if my patient asks me, I say, well, if your POTS is very mild and your feet and legs are red, wear elastic stockings to the knees, 15 millimeter, maybe 20 millimeter. Oops. Sorry. And then if on the other hand, if they have significant POTS, I usually say wear an abdominal binder and wear something else with it. That usually works much better. Counter maneuvers are actually very, very good, particularly in initial orthostatic hypotension. I usually tell the patient when you stand up, stand quickly on your tiptoes for 5 seconds, 10 seconds, or put one foot on a stool or cross your ankles like this one. And that actually seems to work pretty well here, like this one. Yeah. Okay, good. So POTS in Chiari, you get migraines and headaches that are frequently associated with POTS. And then it can be difficult. You've heard a lot about orthostatic headache. But patients, when they have orthostatic headache and Chiari, it's a dilemma. You don't know, do they have a CSF leak or is it a Chiari malformation? And they get other things you've heard about. They can have not only cough headache, but they can have cough syncope. And those seem to be reasonably, fairly unique and specific to patients with Chiari. So you want to expand the plasma volume. We talked about that. There are some meds that can help if patients, for some reason, these don't work or they can't tolerate. Fludrocortisone does that. Desmopressin rarely. You want to put them through an exercise program. There are 2 types of exercise program we recommend. They can actually download them from the web. One is Benjamin Levine exercise program from University of Texas. And then the other one is the CHOP, C-H-O-P, Children's Hospital of Pennsylvania program, which was developed by Jeff Boris, who's a cardiologist in Philadelphia. Patients with mild POTS like the Benjamin Levine Texas protocol. They seem to do well on it. But patients with significant POTS seem to prefer the CHOP program. They find it's a little bit gentler. And they both rely on the fact that you exercise in the sitting position and gradually you increase your span. So out of consideration for the next speaker, I just wanted to show you about this study we did. Basically, so we looked at 110 patients who had postural dizziness in a 6-month period, and we did tilt testing on many of these patients. And 17 of them had normal tilt, but 93 had abnormal tilt with a variety of forms: orthostatic hypotension, neurogenic orthostatic hypotension, and POTS. And interestingly, when we examined those patients, when we were tilting them up or down, we checked their vestibular function. There are ways to do that in the lab. And we found about 25% to 27% can have concomitant mild vestibular signs. And what's interesting is about 4% of patients refer to us for autonomic testing because they have orthostatic intolerance. We find they have no orthostatic problems. It's entirely vestibular. So this is something very relevant, can be playing a role in Chiari. A Korean group had looked at a variety of patients with postural dizziness, and they found actually if you took about 126 patients, 135 patients, 23 patients have migraine, 24 have dysautonomia, and 16 patients will have a psychogenic problem. So with this, I want to thank you for your attention, and I apologize I went a couple of minutes over time. Thank you.